Hello everyone, I am myself Dr. Rajesh Gubba. In this particular session, I'll be discussing a very important topic in the cardiology, that is the jugular venous pressure. So jugular venous pressure is one of the very important part of the examination finding. And what is the importance of it? It tells you about the volume status of the individual. And this jugular venous pressure, it will decide us whether or like how to treat the patient and how to approach the patient. So the overview of the topic what I'll be discussing now is the basic introduction of the JVP, then what exactly is the difference between the internal jugular pulsations and carotid pulsations, why is that we need to choose the internal jugular venous pressure for assessment of the volume status, why not the external jugular vein, or why is that we use the internal jugular vein for assessment of the right atrial pressure, why not the external jugular vein? Why is it only the right internal jugular vein we take, why not the left internal jugular vein? And I will be discussing the interpretation of the jugular venous pulse, wherein I'll be discussing the normal waveforms and the abnormalities of those waves, and some clinical scenarios. I'll be discussing that in the last, or this will be the overview of the topic. So first and foremost, the basic introduction. So what did we discuss in the beginning of the session itself? That JVP, it is one of the very important examination tool, or it is useful for bedside measurement of the volume status of the individual, and this will decide us whether to give diuretic therapy or not. Like for example, you take in patients with a congestive heart failure, based on the JVP level, we will try to adjust the dosage of the diuretics, right? If suppose if the JVP is elevated in a case of congestive heart failure, that tells that the diuretic what we are giving is not of adequate dose and we need to step up the dose of the diuretic. That is one of the clinical application of the JVP. Now, but the raised JVP does not always mean that you need to increase the dosage of the diuretic. Why? Because you take in patients with right ventricular infarction. So in patients with the right ventricular infarction, they will also have the raised JVP. But in these patients with right ventricular infarction with raised JVP, if you increase the dosage of the diuretics, the individual will land up in the hypotension. Okay. So what you have to remember is, in patients with the right ventricular infarction, they will have raised JVP, but they will have the hypotension. So in this case of raised JVP secondary to right ventricular infarction, you should not give diuretics, or you should not increase the dosage of the diuretics. That's a very important point. Okay, but definitely it will tell you the volume status, right? And you need to increase the dosage of the diuretic if the raised JVP is due to congestive heart failure, but not because of the right ventricular infarction. Now the next important point is the jugular venous pulsations or the jugular venous pressure. It tells you about the right atrial pressure, right? And the jugular venous pulsations or the waveforms what we see, and the right atrial pressure changes whatever are occurring, they are not simultaneous. There is a slight pulsation delay between the right atrial pressure changes and as well as the jugular venous waveforms that we are seeing. And how much will be that pulsation delay? That is around 60 to 110 milliseconds. So this is the pulsation delay between the right atrial pressure changes and as well as the jugular venous waveforms that we are seeing. Now, if you take little history about the JVP. Now, who was the person who has first described the jugular venous waveforms? Or the important person is Potain, who has first described, right, who has first described the jugular venous waveform, right? Now, who has given that individual names, that is A, C, X, V, Y, that individual names, and who is the person who has said that JVP is a very important part of the clinical examination? That is James Mackenzie. So he named the JVP waves and he also described the importance of the JVP in the clinical examination. So this is the brief history about the JVP, Potain and as well as the McKenzie. Now, the next important point in the overview was like the differentiation between the carotid pulsations and as well as the jugular venous pulsations. Because whenever you observe the neck, you observe the pulsations of both these vessels depending upon the underlying clinical scenario. In a normal individuals also, you will be able to feel the carotid pulsations. Usually, the jugular venous pulsations are not seen in a normal individual. The jugular venous pulsations or jugular venous waveform is seen in patients with congestive heart failure or right-sided heart abnormality. Now, how will you differentiate? Because both of them, the carotid pulsations and jugular venous waveforms, both of them, they are seen within the neck. So how will you differentiate between these two is a very, very important point. So first and foremost, the position or the appearance or the relation to the sternocleidomastoid muscle. So if you take the carotid pulsations, they are deep, right? They are deep and medial to sternocleidomastoid muscle, right? Deep and medial in the neck, that is deep and medial to the sternocleidomastoid muscle. Whereas you take the jugular venous pulsations are superficial and lateral to the neck, right? Superficial and lateral to the sternocleidomastoid muscle, right? And next important point is about the obliterability. When you apply the pressure or when you apply the pressure with the help of the thumb at the base of the neck, the jugular venous pulsations or waveforms, they are obliterable, right? Whereas the carotid pulsations, they are not obliterable when you apply the pressure with the help of the thumb at the base of the neck, and varying in with position and as well as the respiration. So you take the jugular venous pulsations or the jugular venous volume, it increase on inspiration. But what will happen to jugular venous pressure? The jugular venous pressure, it reduces with inspiration, but the jugular venous volume, it increases with, or the jugular venous pulsations, they increase with inspiration. Whereas the carotid pulsations, they don't have any effect with the respiration, right? And what about the abdominal compression? When you apply the pressure over the right hypochondrium, the jugular venous pressure, it is elevated, right? Jugular venous pressure is elevated when you apply the pressure over the right hypochondrium. But whereas upon abdominal compression, there is no effect on the carotid pulsations and the pulsatility and as well as the waveform. So please remember, the carotid pulsations, they are being felt because they are pulsatile, right? Whereas jugular venous waveforms, they are seen, right? Jugular venous waveforms, they are seen, right? And these jugular venous waveforms, you know, they cannot be felt, right? They are not felt. And in the similar way, the carotid pulsations also, right? You don't have this particular waveform, right? They are being only felt. They are pulsatile, right? They are only pulsatile. Now, what about the peaks and as well as the troughs? If you take the jugular venous pulsations, you have two peaks, that is A and as well as V wave, which we will be discussing. And there are two troughs, right? There are two troughs, right? And these troughs are the X and as well as Y. Now, what about the peaks and troughs in the carotid pulsation? This carotid pulsation, it has a single upstroke, right? It has a single upstroke, that is about the carotid pulsation. So these are some of the difference between the carotid pulsations and as well as the jugular venous pulsations, right? And the next important is, why is that we are choosing the internal jugular vein over the external jugular vein? for assessment of the right atrial pressure changes. So for this, you need to understand a little bit of the anatomy of the jugular vein. Okay, so before going on to that, let me tell you one more difference between the carotid and jugular venous pulsations. You take in a normal individual, the descent in the carotid pulsation, it is rapid, right? The descent in the carotid pulsation, it is rapid, while the descent in the jugular venous pulsations, they are slow. Okay, so that is another important point. So descent in the sense like the decrease in the volume or decrease in the pulsations. It is rapid in case of carotid, and whereas it is slow in case of the jugular venous pulsations, right? Now you need to understand why we need to choose the IJV, why not the EJV. Now for that, let us just discuss the basic anatomy. So there are two important jugular veins. One is the external jugular and as well as the internal jugular. You take the external jugular. So the right and as well as the left external jugular veins, both of them, they drain into the respective subclavian veins. Okay, so the right EJV, it drains into the right subclavian vein, and the left EJV, it drains into the left subclavian vein. Now this particular subclavian veins, they join these subclavian veins, they join with the internal jugular vein. You can see that here, this subclavian vein, it joins with the internal jugular vein to form the brachiocephalic vein. The same way, the left internal jugular vein, it joins with the left subclavian vein to form the left brachiocephalic vein. And this brachiocephalic vein, this is also called as the innominate vein. Now this right and as well as left brachiocephalic veins together, they drain into the superior vena cava, right? Together they drain into superior vena cava, which delivers the blood into the right atrium. So this is the basic anatomy. Now based on this anatomy, now let us discuss why is that we are taking the internal jugular vein as the jugular venous pressure, but why not the external jugular vein. So first and foremost, the very important point is the internal jugular vein is in direct line with the superior vena cava. So you can observe that here. So the internal jugular vein, it is in direct line with the superior vena cava. But whereas the external jugular vein, it is not. So the external jugular vein, it does not have the direct continuity, right? It does not have the direct continuity with the right atrium. So this external jugular vein, in order to open into the superior vena cava or in order to open into the right atrium, it almost take two bends. Okay, the external jugular vein, it almost takes two bends of 90 degrees, right? And because it is taking two bends, there can be pressure changes. The right atrial pressure, exactly, it is not transmitted to the external jugular vein. So it is the internal jugular vein which is in straight connection with the right atrium. That is the reason why the internal jugular vein is taken as the vein which represents the right atrial pressure changes. Next is the course of EJV to the superior vena cava. So if you take the course of the external jugular vein to the superior vena cava, the external jugular vein, it passes through several facial planes. Right? It passes through several facial planes. And when external jugular vein is passing through several facial planes, there is a high chance that it can get obstructed by the facial planes. So that is the reason why your right atrial pressure is not exactly transmitted to the external jugular vein, okay, because it is passing through several facial planes. And next is, if there is any thrombus formation within the bulb of the external jugular vein, even that thrombus formation can cause partial obstruction right, can cause the partial obstruction and there will be rise in the pressure within the external jugular vein, right? And the fourth important is, see, when you are examining the jugular vein, you need to ask the individual to slightly rotate the head towards lateral. So on lateral movement of the head, there can be contraction of the platysma muscle. Now, this contraction of this platysma muscle, that can cause the obstruction, right? That can cause the partial obstruction of the external jugular vein, and thereby the pressure within the external jugular vein can increase, and that can give you a false impression that the jugular venous pressure or the right atrial pressure is elevated. And the presence of valves in the external jugular vein, see, because of the valves, you have the valves in the external jugular vein. So because of the valves, the pulsations in the external jugular vein, they are not clearly seen, right? They are not clearly seen what we observe in the internal jugular vein, right? Internal jugular vein does not have any valves, so thereby you can clearly visualize the pulsations. Next is, in the times of the cardiogenic shock, during the conditions such as cardiogenic shock and as well as in case of the congestive heart failure, in both of these scenarios, there is excessive activation of the sympathetic nervous system. Once there is excessive activation of sympathetic nervous system, that can cause vasoconstriction of the external jugular vein. So once there is vasoconstriction of the external jugular vein, what it tells you, it represents that the EJV is elevated. But once there is vasoconstriction of the external jugular vein, the external jugular vein, it will be small and it is barely visible, right? Small and barely visible. So these are the reasons why the internal jugular vein is like referred over the external jugular vein, right? Next, the next important point is, why is that we are taking right internal jugular vein? Why not the left internal jugular vein? Again, you take the same anatomy. So the right internal jugular vein, it is almost, right? Right internal jugular vein, it is almost in straight line with the superior vena cava, right? And it reflects the hemodynamic changes. The right internal jugular vein, it reflects the hemodynamic changes of the right atrial pressure changes. Whereas you take the left internal jugular vein, it has the angulation. So that is the reason why the right atrial pressures, they are not exactly transmitted to the left internal jugular vein. It is the right internal jugular vein, it is in almost straight line with the SVC. Next is the right innominate vein, which is nothing but the right brachiocephalic vein. There is greater filling of there is greater filling of the right innominate vein from the right side of the head, okay? Whereas you take the left brachiocephalic vein, the left brachiocephalic vein or left innominate vein, it is prone for kinking, right? Or it is prone for compression, right? It is prone for kinking or it is prone for compression between the aortic arch and the sternum, right? Between the aortic arch and the sternum. Now, because it is prone for kinking or compression between the aortic arch and as well as the sternum, what happens now? The pressure whichever is there in the right atrium cannot be reflected exactly into the left internal jugular vein. So that is the reason why we take the right IJV as the representation of the right atrial pressure, but it is not the left internal jugular vein. Next, very important in the discussion is the interpretation of the jugular venous pulse. So like you need to know how to measure the jugular venous pressure, what will be the respiratory variation of the jugular venous pressure and pulsations, what exactly is your hepatojugular reflex, what is positive and what is negative hepatojugular reflex, and what are the various waveforms and what are those abnormalities, all that we will be discussing now. So let me first discuss, or let me first teach you like how to measure the JVP and what should be the position of the individual. See, the position of the individual should be with head end inclined 45 degrees. The patient should be lying comfortably in semi-reclining position with 45 degrees between the trunk, and as well as the angle of the bed, right, and the bed. So, and how should be the head? The head should be slightly rotated towards left. Right, the head should be slightly rotated towards left so that the muscles are relaxed and you can clearly visualize the jugular venous pulsations. Now, why is that we are making the individual to lie down in 45 degrees? Why is that we are not examining the JVP in sitting posture? Or why is that we are not examining the JVP in completely supine posture? See, if the individual, you take in a healthy person, in sitting posture, the jugulars, right, the jugulars, they are collapsed in a healthy individual. Whereas you take in supine posture, the jugulars, they are distended to variable degree, right, they are distended to variable degree when the individual is lying down in supine position. So now in supine position, the jugulars are distended to variable degree. In sitting posture, the jugulars are being collapsed. Now you need to take an intermediate position now, right? You need to take an intermediate position. So you need to select an appropriate intermediate position that permits an individual to see the top of the pulsating column between the clavicle and as well as the mandible. Now, what will be that intermediate position? That intermediate position will be around 30 to 60 degrees. That will be the intermediate position. So, in between this 30 to 60 also, a standard is being maintained. And how much is that standard in between 30 to 60 degrees? That is 45 degrees is the standard in which the JVP has to be examined. Now, sometimes what happens is, you will notice that the pulsations are going up to the jaw, right? The jugular venous pulsations, you may notice that they are going up to the jaw. And even you can observe the jugular venous pulsations even near the ear lobes. So, pulsations when they are going up to the jaw, when the individual is in 45 degrees or 90 degrees, that means that the right atrial pressure, it is elevated to more than or equal to 25 millimeters of mercury. Okay, so this is one representation. So why is that we are taking 45 degrees? Because in complete supine position, the jugular venous pulsations, they are like variable. Whereas in sitting posture, the jugular venous waveforms, they are collapsible. So you have to take an intermediate position, that is between 30 to 60 degrees. And between 30 to 60 degrees, you take a standard position, that is 45 degrees, and then you need to examine the JVP. Now, coming to the measurement of the jugular venous pulsations. So, for the measurement of the jugular venous pulsations, you require two scales. Okay, one is placed horizontal to the upper level of the pulsation. Okay, so this is the first scale, right? This is the first scale which is placed exactly horizontal to the upper level of the pulsations, right? And what about the another, that is second? The another you should take exactly, or you should place exactly perpendicular to the first scale over the sternal angle, right? Over the sternal angle. So this is what is the position of the two scales, right? So one placed horizontal to the upper level of the pulsations, and another taking the vertical distance of the ruler from the sternal angle. Now, whatever this vertical distance is there, right? Whatever the vertical distance is there from the bifurcation of the two scales up to the sternal angle, that we take into consideration as the jugular venous pulsations. Let us just assume it is around 3 centimeters. To this, you need to add 5 centimeters because the distance between the sternal angle and as well as the center of the right atrium is around 5 centimeters. So, right, in a normal individual, how much it will be? In a normal individual, it will be around 6 to 8 centimeters of water. Right, 6 to 8 centimeters of water. Okay, at an individual position at 45 degrees. So the JVP is usually measured in centimeters of water or the inches of water. Okay, right. So this is how you need to measure the JVP. Now what about the respiratory variations of the JVP? So during inspiration, the jugular venous pulsations, they're increased. Now why is that? Why? Because during inspiration, the venous return increases to the right atrium. So as the venous return increases, the right atrial pressure increases, right? And as the right atrial pressure increases, the jugular venous pulsations also, they increase, right? But what will happen to the mean jugular venous pressure during inspiration? The mean jugular venous pressure falls during inspiration. Now why is that? That is because from during inspiration, the venous return to the right atrium is increasing. That means even from the jugular vein, the blood is entering into the right atrium. So the mean jugular venous pressure falls, but the jugular venous pulsations, or there will be jugular venous distension which will happen during the inspiration. Now what about the Kussmaul sign? So what did we discuss? During inspiration, the mean jugular venous pressure decreases. So Kussmaul sign is if mean jugular venous pressure increases on inspiration, that we call it as the Kussmaul sign. It is exactly opposite to that of the normal phenomenon, right? And you come across this in multiple conditions, like constrictive pericarditis is one of the very important condition, and we have many other conditions like, okay, let me tell you all the conditions and then I'll explain to you the mechanism of the Kussmaul sign as well. So in patients with right heart failure, in patients with tricuspid regurgitation, pulmonary stenosis, pulmonary hypertension, next cor pulmonale, next in patients with constrictive pericarditis, then in cardiomyopathies like restrictive cardiomyopathy. So these are all the conditions where you will have a positive Kussmaul sign, or the Kussmaul sign is being present, where the JVP is elevated on inspiration. Now let me try to explain you the mechanism by taking one important condition, that is the right heart failure. So if you take this right heart failure, okay, let us just assume this is the right atrium and this is the right ventricle, right, which is giving rise to the pulmonary artery, and it is dividing it into the branches, right? It is dividing into the branches. So you have right atrium and as well as the right ventricle. Okay, right. Now the right ventricle is failed. So once the right ventricle is being failed, what will happen? RV, end systolic volume, will be increased, right? Yes or no? Because the right ventricular contractility is reduced, so the stroke volume from the right ventricle into the pulmonary artery will be reduced. So RV end systolic volume will be increased. Now to this, the right atrium will be sending the blood to RV during the diastole. So now to this RV end systolic volume, the RA blood is added. So thereby what will happen to your RV end diastolic volume? Increases. When RV end diastolic volume increases, subsequently there is also increase in RV end diastolic pressure. So in patients with right heart failure, what is happening is there is increase in RV end diastolic pressure. Okay. Now during inspiration, right, during inspiration, the venous return to the right atrium increases. Right, the venous return to the right atrium increases from superior vena cava and inferior vena cava. Now this entire blood which has reached the right atrium, it has to come to the right ventricle. But how is your RV end diastolic pressure? It is elevated. So when your RV end diastolic pressure is elevated, your right atrium, it is not in a position to send the blood adequately into the right ventricle because RV end diastolic pressure is elevated. Now once right atrium cannot send the blood to the right ventricle, right atrial pressure is also elevated. Okay, so subsequently to this, what will happen? The right atrial pressure is also elevated because right atrium is unable to send the blood into right ventricle. So once the right atrial pressure is elevated, now what will happen? The superior vena cava and as well as the inferior vena cava, they are unable to pump the blood adequately or unable to pump the venous return adequately into the right atrium. So thereby what will happen to the pressures within the SVC and IVC during inspiration? They increase because venous return has to go into right atrium and jugular venous pressure has to fall in a normal individual. But here what is happening? Right atrium is not in a position to receive the blood from superior vena cava and inferior vena cava. So thereby your SVC pressure and IVC pressure will be elevated. So JVP will be elevated during inspiration and that we call it as the Kussmaul sign. Okay, so Kussmaul sign are seen in conditions or all the conditions wherever you have the right heart failure. Then in conditions like constrictive pericarditis and as well as the restrictive cardiomyopathy. So this is about the Kussmaul sign. Now you have to understand the Kussmaul sign is different from the Kussmaul's respiration. Kussmaul's respiration, you come across that in patients with the diabetic ketoacidosis where the individual will have a periodic breathing, right? Next, now we will move on to the another important component or another important part of the jugular venous examination, that is the hepatojugular reflex. Now what exactly is this hepatojugular reflex and why is it important? Let me explain to you. Okay, so before going on to the hepatojugular reflex, one more point that you need to understand is that we have two important clinical conditions, that is cardiac tamponade and as well as SVC obstruction. In both of these conditions, the JVP is elevated. Right? In both of these conditions, the JVP is elevated. In spite the JVP is elevated, you don't see the Kussmaul sign. Right? In spite the JVP is being elevated, there is no Kussmaul sign. Okay. Why is that? Because in cardiac tamponade, there is absence of certain waves. And in superior vena cava obstruction, because of the obstruction, the right atrial pressure changes are not reflected into the jugular vein. So that is the reason why in cardiac tamponade and as well as the superior vena cava, it is non-pulsatile increase in the JVP. Right? Non-pulsatile increase in the JVP. Whereas Kussmaul sign, what do we discuss or what do we describe as? It is pulsatile increase in the JVP during inspiration is called Kussmaul sign. But whereas here it is non-pulsatile increase in the JVP. So that is a very, very important difference that you need to make out. Right? Now, let me discuss about the hepatojugular reflex. What is the normal hepatojugular reflex? The normal hepatojugular reflex is that what you have to do, you have to apply the pressure over the right hypochondrium, right? You need to apply a gentle pressure over the right hypochondrium. So with this application of the gentle pressure over the right hypochondrium, the pressure within the right hypochondrium has to build up. how much it has to build up? It has to build up over 20 to 35 millimeters of mercury. Right? It has to build up over 20 to 35 millimeters of mercury. Right? Within how much duration? Within 15 seconds. Right? Within 15 seconds duration, the pressure within the right hypochondrium should be elevated over 20 to 35 millimeters of mercury. Now, once you apply the pressure over the right hypochondrium, what is that you are doing indirectly? You are like squeezing the liver. So thereby, what will happen? The venous return to the hepatic veins increases, and subsequently the venous return to the inferior vena cava increases, and from the inferior vena cava the venous return increases to the right atrium. So the right atrial pressure is elevated. So once the right atrial pressure is elevated, that is reflected to the jugular vein. So jugular venous pressure is elevated. Okay, and how much that jugular venous pressure rises? Normally the pressure rise will be less than 3 millimeters of mercury, and this pressure rise, whatever is there, it is transient. So this pressure rise, it will return back to normal, right? It returns back to normal within 10 seconds, right? Within 10 seconds, the JVP will return back to normal, right? That is the normal hepatojugular reflex, which is also called negative hepatojugular reflex. Then what is positive hepatojugular reflex? Positive hepatojugular reflex is that the jugular venous pressure, it is elevated more than 3 centimeters of water for the entire duration of the compression, and even after the release of pressure, right, even after the release of pressure from the right hypochondrium, the JVP is still elevated for more than 15 seconds. That is called a positive hepatojugular reflex. So normally once you remove the pressure from the right hypochondrium, the JVP will return back to normal within 10 seconds. But in spite of taking out the pressure from the right hypochondrium, the JVP is still elevated more than 3 centimeters for more than 15 seconds. That we call it as the positive hepatojugular reflex. Now, what are the conditions where you will have the positive hepatojugular reflex? Remember, the positive hepatojugular reflex, it is the earliest sign of incipient right heart failure. Now, what do you mean by the word incipient right heart failure? That is latent, right? Before the appearance of raised JVP, the sign which is present before the raised JVP will be positive hepatojugular reflex. So the hepatojugular reflex, it is being positive in right heart failure and in all the conditions whichever causes the right heart failure, like tricuspid regurgitation, pulmonary hypertension, pulmonary stenosis, pulmonary embolism. In all these conditions, you can have a positive hepatojugular reflex. Now, what are the conditions where you will have false positive hepatojugular reflex? That is, in chronic obstructive lung diseases, you can have false positive hepatojugular reflex. Next, in conditions where there is loss of vital capacity within the lung, right? Lung conditions with loss of the vital capacity, right? And the other conditions where there can be false positive hepatojugular reflex is in individuals with excessive sympathetic stimulation and in conditions like extreme nervousness. So these are the conditions where you will have the false positive hepatojugular reflex. Now, let us just discuss the identification of the individual waves. So, identification of waves, this comes with the experience. This comes with time. Now, what are these waves? We have A, C, X, V, Y, and occasionally you will have this H wave as well. So out of these ACX, V, Y, you take this A wave, it is a positive wave. V wave, this is also a positive wave. And X and Y waves, they are the negative waves. Right? X and Y waves, they are the negative waves. So like you take a positive wave. That means during your A and as well as V, there is increase in the right atrial pressure. Whereas during X and as well as Y, there is decrease in the right atrial pressure. Right? So two crests, two troughs. Now, why these particular waves appear and what does these waves indicate and how is that you will correlate with the cardiac cycle events, all that let me try to discuss now. So you take the individual waves, that is A wave. So A wave, it occurs due to the atrial contraction. So what does the A wave tells you? The pressure within the right atrium increases. So whenever there is atrial systole, right? So whenever there is atrial systole, there is increase in the right atrial pressure, right? And that increased right atrial pressure is represented by the A wave, right? And it is the dominant wave which is occurring before the carotid pulsations. And it is the dominant wave before the appearance of the S1, right? So before S1, you get this particular A wave, okay? Now, once the atria is contracting, ventricle will be in a state of the relaxation, right? Atrial systole is your A wave, ventricle will be in a diastole. Now, what will be the next event? The atria will be relaxing and ventricle will be contracting. So, X wave is due to what? After the atrial contraction, the next event is the atrial relaxation. So X wave is due to the atrial relaxation. Right? It is due to the atrial relaxation. Now what about the C wave? I will explain to you. But this X wave, it is primarily due to atrial relaxation. And this particular X wave, again, we have two things, right? Or we have two components. One, we have X and as well as the X dash. Now, what is this X and X dash? For that, you need to understand first what exactly is the C wave. Now, you see, now when atria is relaxing, what the ventricle will be doing? Ventricle will be contracting. When ventricle contracts, okay, so let us just assume this is the right atrium and this is the right ventricle and this is the tricuspid valve which is connected to chordae tendineae to the papillary muscles, right? So when the right ventricle it is contracting, the pressure within the right ventricle increases, and as the pressure within the right ventricle increases, that pressure is exerted to the tricuspid valve leaflets, and these particular tricuspid valve leaflets, right, these particular tricuspid valve leaflets, they are pushed into right atrium, right? These tricuspid valve leaflets, they are pushed into right atrium during right ventricular contraction. So once the tricuspid valve leaflets are pushed into right atrium, what will happen to the right atrial pressure again? The right atrial pressure again it increases, and that is what is your C wave, okay? So C wave, it appears during the X wave descent. So the C wave, it tells you that the cusps, they are bulging into right atrium, right? Cusps, they are bulging into right atrium. So C wave is due to bulging of the cusp into right atrium, that is tricuspid valve cusps. And where are these particular, or where is this C wave? The C wave, it is present on the descent of the X wave. Okay. Now, so we were discussing about the x and as well as the x dash. So the initial x wave is due to atrial relaxation. Now what about this x dash component? This x dash component, it's a part of the atrial relaxation, but during that x dash component, what has happened during the C wave? The tricuspid valve has bulged into the right atrium, and during this x dash, the entire tricuspid valve ring, it descends downwards. Okay, so this x dash, it is due to descent of the tricuspid valve ring. Along with that, the tricuspid valve cusps. This entire thing will be descending down. So once this tricuspid valve cusps, once they are descending down back again, you get this x dash. Okay, so x wave is due to atrial relaxation, and x dash, it is due to downward movement or due to descent of the tricuspid ring caudally during the ventricular contraction. That is about the x dash. Then followed by that the V wave. So V wave, it is again a positive wave, and that is due to venous filling. Right, that is due to venous filling. So the right atria, it is receiving the blood from superior vena cava and as well as the inferior vena cava. So once right atria is receiving the blood from superior vena cava and inferior vena cava, the right atrial pressure increases, and thereby you get this particular V wave. So V wave is due to venous filling, and this particular V wave, it is seen due to rise in right atrial pressure because of the venous filling. And you have to remember that this particular V wave, it is the one which appears after this particular X wave. Okay, then coming to the Y wave. So Y wave, it is again a negative deflection. So Y wave is due to atrial emptying. So now what has happened now? During the venous filling, the right atrial pressure is very much elevated. So once the right atrial pressure increases, that increased right atrial pressure will open the tricuspid valve, and once the tricuspid valve opens, the blood from the right atrium gushes into the right ventricle, and thereby there will be atrial emptying, resulting in Y wave. So Y wave is due to atrial emptying. Right, it is due to atrial emptying. So that is the Y wave. Okay, so Y wave, it is again a negative wave. And one more important wave is the H wave. The H wave, usually it is not seen. Right, this particular H wave, it is the one which is present before the A wave. That means it is a pre-systolic, right, wave. But pre-systolic wave of what? Not the ventricle. So it is a pre-systolic wave of the atria. Atrial contraction will cause the A wave. Just before the A wave, you get this particular H wave. And this H wave, it is usually seen during the slow heart rate. When there is like bradycardia, you get this, the H wave. Okay, and it occurs due to passive right heart filling during the diastole. Right, passive right heart filling during the diastole, and it is the one which occurs just prior to the A wave. Right, so this is about the individual waves of the JVP. But very important point now is you should be able to correlate that with the events of the cardiac cycle. Now, first of all, let me just give you a brief review of what are the events within the cardiac cycle. So if you take the events in cardiac cycle, we have the systole and then the diastole. Okay, so systole or systole, we have isovolumetric contraction phase, then we have the first rapid ejection, then followed by that we have the slow ejection. Okay, these are the events in the systole. Whereas you take in the diastole. In the diastole, like you have the protodiastole, right? Or some textbooks gives directly that there is presence of isovolumetric relaxation phase, then followed by that you have first rapid filling. Then this first rapid filling, this is due to the opening of the tricuspid and as well as the mitral valve. And then we have diastasis, right, which is the passive filling. Then we have the second rapid filling, and this second rapid filling, this is due to the atrial contraction that will cause the second rapid filling of the ventricle. And all the events in the cardiac cycle, whatever are being described, they are the ventricular events, not the atrial events. So with these events, you need to correlate the atrial events. Now, let me try to correlate these cardiac cycle events with the mechanical events of the atria and the jugular venous waveforms. So, like you take the first one, that is the A wave. So A wave, it occurs due to atrial contraction. Now when is your atria contracting? That is during second rapid filling. So what will be that now? That will be during the end diastole. Right, that will be during the end diastole. And C wave, it is due to bulging of the cusp. When is the cusp bulging? That is during isovolumetric contraction phase. And isovolumetric contraction is what? The isovolumetric contraction, it is the early part of the systole. So C wave, it is due to the early or during the early systole. Then you take the X wave. So X wave is during, it is due to atrial relaxation. Now when atria is relaxing, what the ventricle will be doing? The ventricle is in contraction state still. That is, the ventricle is in a state of the mid systole, or the cardiac cycle will be like in the mid systole. And V wave is what? That is due to venous filling. So venous filling of the atria, that is superior vena cava and inferior vena cava, will be giving the venous return to the right atria. So that means during the venous filling, the atria is in a state of relaxation. So what the ventricle will be in? The ventricle will be in a phase of the systole. But which phase of the systole? That will be late systole. Right, that will be the late systole. Then followed by that, like we have the Y wave. Now, why is this particular Y wave? Due to atrial emptying. Now, when is the atria emptying? The atria, right? So when atria is emptying means like ventricle should be in a position to receive the blood. That means the ventricle is in the early part of the diastole. So your Y wave, it represents the early diastole. Okay, so these are the correlation between the mechanical events of the atria with correlation with the phases of the cardiac cycle. Now, let me try to correlate this JVP waves with the heart sound. See, now correlating that with your cardiac cycle events is like conceptual. But whenever you are seeing the waves in the JVP, you should be able to identify whether it is A wave, C wave, X wave, V wave or Y wave. So, you take S1. S1, it exactly corresponds to the C wave. Okay, because it is during the C wave there is isovolumetric contraction phase. And during isovolumetric contraction phase, you will listen the first start sound. That means whenever you are listening the first start sound, the wave what you are seeing is a C wave, and just before the first start sound, you get the A wave. Right? Just before the first start sound, what you get is the A wave. Then you take the S2. S2, after the S2, the peak, whatever you are seeing, will be the V wave. Okay, so you will listen S2 first. After S2, you will have V wave. So that means you just see here, between S1 and S2, what are the waves that you will see within the JVP? So this will be C wave, and between S2 and as well as S1 again. Just before S1, what did we discuss? This will be A wave, just before the S1. Then when will your V wave peaks? Just after S2, you have the V wave peaking. Then what are the other waves now? You have A, C, and then X. X wave is that which you will visualize between S1 and S2, which is due to atrial relaxation. And what will be the ventricular event during the X wave? That is the mid-systole. So between S1 and S2, you have the X wave. Then you have A, C, X, V, and then you have the Y wave here. Between S2 and S1, you have the Y wave. Okay, so this is how you will be able to make out the JVP waves by auscultation, right? So the rapid upstroke, whatever you are having, is the C wave, and the downstroke you can see is the Y wave. Okay, right. So this is about how you will be able to identify the JVP waves by the auscultation. And not only that, whenever you are like visualizing the JVP waves, what you have to do is you need to palpate the opposite carotid artery simultaneously in order to make out the events of the cardiac cycle, or you need to auscultate over the precordium while visualizing the JVP waves. Now, after having discussed about the normal waveforms, now let me take up the discussion of the abnormal waveforms. So now let me first discuss the abnormalities of the A wave. So in the abnormalities of the A wave, you have the conditions where there is increased form of the A wave, that is giant A wave and as well as Cannon A wave. And there are certain clinical conditions where you have the absent A wave. Now, when do you call it as the giant A wave is when the right atrial pressure is around 6 to 15 millimeters of mercury. And when do you call Cannon A wave is when the right atrial pressure is elevated to more than or equal to 16 millimeters of mercury. We call it as the Cannon A wave. Now, let me first explain you the conditions where you will have the giant A wave. So giant A wave, like you can see in conditions where there is obstruction at the right inflow tract, that is your right ventricular inflow tract, and obstruction at the right ventricular outflow tract. Now what is that? Let me try to explain to you. So if the pathology is at the level of the tricuspid valve, like for example tricuspid stenosis and right atrial myxoma. So when there is tricuspid stenosis, you can see here the tricuspid valve is stenosed. So in order to send the blood from right atrium to right ventricle, the right atrium has to do excessive work, or right atria has to contract strongly to push the blood into the right ventricle. So when there is a stronger right atrial contraction and when the right atrial pressure is elevated to 6 to 15 millimeters of mercury, then you get this giant A wave. And you take in case of right atrial myxoma. See, in case of right atrial myxoma, right atrial myxoma is that it's a tumor which is originating from interatrial septum and it will overlap the right ventricular inflow tract, right? And when the right atrial myxoma is obstructing the right ventricular inflow tract, right atrium has to do excessive work in order to pump the blood into the right ventricle. So thereby what will happen to right atrial pressure? Again it is elevated and thereby you get the giant A wave. So the tricuspid valve pathology like tricuspid stenosis, and then the conditions like the tricuspid atresia where there is abnormality within the tricuspid valve, then the presence of thrombus within the right atria. Next, in conditions like lupus endocarditis, because lupus endocarditis there can be involvement of the tricuspid valve. Then in carcinoid syndrome. because in carcinoid syndrome there can be tricuspid stenosis or tricuspid regurgitation, or even there can be pulmonary stenosis also. So that can cause the increase in right atrial pressure resulting in giant A wave. So the pathology can be either in the tricuspid valve, the pathology can be at the interventricular septum, or even at the level of the pulmonary valve. Now, what are those interventricular septal pathology causing the giant A wave? So interventricular septal pathology, that includes right ventricular hypertrophy. So when there is right ventricular hypertrophy, what will happen to the right ventricular end diastolic pressure increases. So once the right ventricular end diastolic pressure increases, right atria has to contract very strongly to push the blood into the right ventricle. So once the right atria contracts strongly to push the blood into right ventricle, again you get this particular giant A wave. Next is subvalvular stenosis. So even in case of subvalvular stenosis of the pulmonary valve, what happens here? Again, the right ventricular pressure increases. So as the right ventricular pressure increases, right atria has to contract very strongly to push the blood into right ventricle. Again, the right atrial pressure increases, and that will result in the giant A wave. Next is the pathology beyond the right ventricle, that is the pathology at the level of the pulmonary valve. So you take in case of the pulmonary stenosis. In pulmonary stenosis, right ventricle has to contract very strongly to push the blood into the pulmonary artery. Thereby, right ventricular systolic pressure and subsequently right ventricular end diastolic pressure increases. So once your right ventricular systolic and right ventricular end diastolic pressure increases, even right atria also has to contract very strongly to push the blood into the right ventricle during the diastole of the right ventricle. Thereby the right atrial pressure increases. Okay, that means once right atria is contracting very strongly, you get a giant A wave. So pulmonary stenosis, then pulmonary hypertension, then pulmonary embolism. So right, so these are the conditions where you can have the giant A wave when the pathology is beyond the right ventricle, or even in case of pulmonary regurgitation as well. So these are all the conditions where you will have the giant A wave. Next is coming to the concept of what is called as the jugular corrigens. See, jugular corrigens is that it is the comparison of the A wave with the V wave. A wave is also a positive wave, that is due to atrial contraction. V wave is also a positive wave, that is due to venous return through superior and as well as inferior vena cava. But if the amplitude of the A wave is much more than V wave, and how much it should be? The A wave amplitude, it should be 6 to 15 centimeters higher. Right, the A wave amplitude, it is 6 to 15 centimeters higher, then we call this as the jugular corrigens. Okay, next, then followed by that, what exactly you understand by this word A wave? Cannon A wave. So cannon A wave, what did I tell you? The right atrial pressure should be elevated more than or equal to 16 millimeters of mercury. Now this cannon A wave, you can have this either irregular cannon A wave or the regular cannon A wave. Now what are the, first of all let me explain you the concept of the cannon A wave. Why you get the right atrial pressure being elevated more than or equal to 16 millimeters of mercury. See, what should happen whenever the right atria is contracting, right ventricle should be in a state of relaxation and right ventricle should be in a position to receive the blood from the right atrium. But let us just assume that there is a complete heart block. Right, there is a complete heart block. So once there is a complete heart block, what will happen? The right atria, it contracts on its own, and right ventricle also will contract on its own. Now for suppose when right atria and as well as right ventricle, both of them are contracting simultaneously. Right, both of them, they are contracting simultaneously. What will happen? When both right atria and as well as right ventricle are contracting simultaneously, what happens is right atria has to contract against the closed tricuspid valve. Why? Because when right ventricle is contracting, what will happen to the tricuspid valve? The tricuspid valve, it closes. Okay, So when right atria is contracting simultaneously along with right ventricular contraction, you see how is the scenario now? The right atria has to contract against the closed tricuspid valve. So when right atria has to contract against the closed tricuspid valve, the right atria has to contract very strongly to push the blood into right ventricle, and thereby the right atrial pressure will be elevated more than or equal to 16 millimeters of mercury, and that will result in what is called the Cannon A wave. Now, what are the conditions where you will have the irregular Cannon A wave? The irregular Cannon A wave, you come across that in patients with the complete heart block, and you come across this in patients with the ectopic beats, that is the ventricular ectopic beats. So when there is a ventricular ectopic, right, so like when the atria is contracting, during the time of the atrial contraction there is a ventricular ectopic. So what will happen? The atria and ventricle, they are contracting simultaneously, and right atria has to contract against the closed tricuspid valve, resulting in the irregular Cannon A wave. Then followed by that, you need to know about the regular Cannon A wave. So if you take this regular Cannon A wave, you come across this in patients with AV nodal reentrant tachycardia and atrioventricular reentrant tachycardia. So these are the two conditions where you will have regular Cannon A wave. Then in conditions like 2:1 AV block, you will have the regular Cannon A wave. And even in case of slow VT, there also you can have a regular Cannon A wave. So the concept is very simple. When both the right atria and right ventricle are contracting simultaneously, the right atria, it has to contract against the closed tricuspid valve, and the pressure within the right atria increases to more than or equal to 16 millimeters of mercury, and that will result in the Cannon A wave. Now you need to know what is the frog positive sign within the JVP. So basically it is nothing but, in case of complete heart block, what is the happening, or what exactly is the scenario? Right atria is contracting against the closed tricuspid valve, and what has happened to right atrial pressure? It is elevated much more. Then that is, it is elevated to more than or equal to 16 millimeters of mercury. So in that scenario, what happens? So when there is pronounced efflux of blood, right, once there is pronounced efflux of blood during simultaneous right atrial and as well as right ventricular contraction, okay, and where is that pronounced efflux of the blood? This pronounced efflux of the blood is into the jugular veins. So thereby what will happen to the neck pulsations? The neck pulsations, they become more prominent, like the pulsations what you will see within the frog's neck, and that is the reason why that is the reason why it is called as the frog positive sign. Okay, it is the one which has been described by Brugada. So this frog positive sign within the jugular vein is seen in case of the Cannon A wave, particularly like complete heart block. Then you should know the conditions where there is the absent A wave. Absent A wave means what? The pressure within the atria is not increasing during the atrial contraction. That is what is the representation of the absent A wave. And you can have that in two conditions. One is atrial fibrillation and the other one is the Epstein's anomaly. So in atrial fibrillation, it is the feeble contraction of the atria. Now in atrial fibrillation, what will be the rate of the atrial contraction? The rate of atrial contraction is around 300 to 400 per minute, right? Now when atria is contracting at a rate of 300 to 400 per minute, what will be the intensity of the atrial contraction? It will be a feeble atrial contraction. Once there is a feeble atrial contraction, the right atrial pressure is not elevated, and thereby you will have no A wave. There is absent A wave. Okay, Whereas you take the Epstein's anomaly. What exactly is your Epstein's anomaly? It is the atrialization of the right ventricle. That is what is called as the Epstein's anomaly. So here you will have a giant silent right atrium. You will have a giant silent right atrium. That is what you will come across in case of the Epstein's anomaly. So it is this giant silent right atrium. This particular silent right atrium, it does not have effective mechanical systole. Right? It does not have the effective mechanical systole. So thereby you don't have the A wave. So in Epstein's anomaly and as well as in atrial fibrillation, there is no A wave. So these are the abnormalities of the A wave. So A wave is absent in case of the Epstein's and as well as the atrial fibrillation. Giant A wave, it is seen in conditions like tricuspid stenosis, right atrial myxoma, right atrial thrombus, carcinoid, lupus endocarditis. And in conditions, giant A wave is also seen in conditions like right ventricular hypertrophy and subvalvular stenosis. And pulmonary valve pathology causing the giant A wave is like pulmonary stenosis, pulmonary regurgitation, pulmonary hypertension, pulmonary embolism. And the Cannon A wave, you have irregular Cannon A wave in case of complete heart block and ectopic beats. And regularly irregular Cannon A wave, that is being present in case of AV nodal reentrant tachycardia and as well as atrioventricular reentrant tachycardia, right? So these are the abnormalities of the A wave. Now let me try to explain to you about the abnormalities of the X descent. So X descent tells you what? The X descent, it tells you about the atrial relaxation. Now there are certain conditions where the X descent is absent. What is that condition? That is tricuspid regurgitation. Why? I'll explain to you. Now what are the conditions where there is increase in the depth of the X wave? That means the X descent is exaggerated. That you come across in patients with restrictive cardiomyopathy, then in conditions like cardiac tamponade, then in conditions like constrictive pericarditis. Okay, so these are the conditions where you have increase in the depth of the X descent. Now let me try to explain to you the concept of tricuspid regurgitation, why the X wave is absent. So let us just assume this is the right atrium, right ventricle with continuation as the pulmonary artery, which is dividing into the right and as well as left pulmonary artery. Now in tricuspid regurgitation, what happens? When the right ventricle is contracting, what the right atria is doing? Right atria is relaxing. So the pressure within the right atria reduces and thereby you get a X wave. Okay. Now in tricuspid regurgitation, what happens? When right ventricle is contracting, some amount of blood, it will be leaking into the right atrium. Normally the right atrium is relaxing when the right ventricle is contracting and the pressure within the right atria is falling down, thereby you get an X wave. But what is happening here? The blood is leaking during the right atrial relaxation or the right ventricular contraction. So the fall in the pressure in the right atrium does not occur. Why? Because right atrium, it is receiving the TR blood. So the pressure fall within the right atrium will not be there because of the leakage of the blood. Thereby you will not have the X wave. There is absent X wave in case of tricuspid regurgitation. Whereas you take in these conditions, why you have exaggerated X descent is, in all these conditions, restrictive cardiomyopathy, constrictive pericarditis and as well as cardiac tamponade, there is increase in your RV end diastolic pressure. Once there is increase in your RV end diastolic pressure, right atria cannot send the blood adequately to right ventricle. So right atria will try to distend maximally or it will try to relax maximally to accommodate the blood which is not being received by the right ventricle, and thereby you get this exaggerated X wave in constrictive pericarditis, restrictive cardiomyopathy and as well as the cardiac tamponade, right? So this is the JVP representation of the absent X wave. You see here, you have the C wave, right? After the C wave, directly you have the V wave. You don't have this X descent in case of the tricuspid regurgitation, right? Now, increase in the depth of the X descent, just now we have discussed the conditions. Now, abnormalities of the V wave. So, if you take the abnormalities of the V wave, there is one condition where the V wave amplitude is increased. So, what is that condition where the V wave amplitude is being increased? Again, it is the same story, that is tricuspid regurgitation. Now, why is that? Let me try to explain the concept once again. V wave is actually due to what? The V wave, it is due to the venous return. Okay. So, when the right ventricle, it is contracting, some amount of blood is leaking back into right atrium. Now, right atria is relaxing. So, during the phase of the right atrial relaxation, right atria is receiving the blood from superior vena cava and right atria is receiving the blood from the inferior vena cava, right? So, into the right atria, you have the SVC blood, you have the IVC blood, and you have the TR blood, that is the tricuspid regurgitant blood. So now thereby, what will happen to the amplitude of the V wave? The amplitude of the V wave will be increased, okay, because it has the additional blood which has received now. So thereby the V wave amplitude is increased, and that is what is being represented here also. So you can see that the V wave amplitude in case of the tricuspid regurgitation, it is greatly increased, right? Now, after having discussed about the abnormalities of the V wave form, okay, one point that I have to tell you is this increased V wave, which is seen in case of tricuspid regurgitation, that particular sign is called as Lanz-CC sign. And this will be an important multiple choice question, right? Then, now, the other conditions where you can have this increased amplitude of the V wave, that is in patients with atrial septal defect, right? The concept is very simple. Whenever there is an ASD, the blood from left atrium will be entering into the right atrium, right? And thereby the V wave amplitude increases, right? And the other conditions where you can have this particular large V wave is in patients with total anomalous pulmonary venous connection. So this pulmonary veins, instead of draining into the left atrium, the pulmonary veins are draining into the right atrium. So thereby again you get this large V wave, okay? And even in case of hyperdynamic circulatory states, these are also the conditions where you can have the large V wave, okay? So you can see this prominent V wave in ASD, TAPVC, and as well as hyperdynamic circulatory states. Now let me discuss the abnormalities of the Y wave. Y wave is what? It is atrial emptying, right? So Y wave, it is a negative wave. Now, why is that you are getting the negative wave? That is because the atria or your tricuspid valves, they have opened. Once the tricuspid valves have opened, what will happen? The blood from the atria will gush to the ventricle. Once the blood gushes to the ventricle, the pressure within the atria decreases, and thereby you get this Y wave. That is what we have discussed in the beginning also, right? And what are the conditions where you will have slow Y descent? That is in tricuspid stenosis, right? It is obvious, right? The tricuspid valve is narrowed. So the atrial emptying, it is slow and delayed. So thereby you will have slow Y descent. Then rapid and deep Y descent, you come across this in patients with constrictive pericarditis. Then in patients with restrictive cardiomyopathy. Then absent Y wave, you see this in patients with the cardiac tamponade. See, why is that in patients with the cardiac tamponade, the Y wave is absent? Because let us just assume this is like 4-chambered heart and this is the pericardial space. And what has happened to the pericardial pressure? It is grossly elevated or rapidly or abruptly elevated in case of cardiac tamponade. Once the pericardial pressure is rapidly and abruptly elevated, what happens? The ventricles, they cannot relax. So the end diastolic pressures of the ventricle grossly increases. Once the end diastolic pressure of the ventricle grossly increases, the atria, they cannot empty. Once atria, they cannot empty the blood, you don't have the Y wave. That is what happens in cardiac tamponade. So there is diastolic collapse of the ventricles in cardiac tamponade. So that is the reason why you don't have this Y wave. Okay. Now, then what are the conditions where you will have a prominent Y descent or rapid Y descent? So prominent Y descent, you have that in tricuspid regurgitation. Why? Why? Because in tricuspid regurgitation, just now we have discussed that the right atria is having SVC blood, IVC blood, and as well as the TR blood. So now subsequently, when the atria is emptying, the atrial emptying will be more, that is large volume of the blood will enter back into the right ventricle. So thereby you will have a prominent Y descent. Thereby you have a prominent Y descent. Okay. So this is about the abnormalities related to V wave. So you can just see here, right? So this Y descent, whatever is there, it is like very prominent and rapid. That is what you will see in case of the tricuspid regurgitation. So in tricuspid regurgitation, right, one more important sign that you need to know is the Frederick sign. Now in tricuspid regurgitation, what did we discuss? We have discussed that you have the absent X wave, right, absent X wave, and there is prominent V wave, and there is prominent Y descent. Right, prominent Y descent. That is what we have discussed in tricuspid regurgitation. Frederick sign is the JVP sign in the constrictive pericarditis, where we have rapid Y descent, right, where we have the rapid sharp Y descent without prominent V wave. Actually, when will you have a prominent Y wave or rapid Y descent? You will have rapid Y descent when there is a prominent V wave, like in case of tricuspid regurgitation. But here you will have you are having a rapid Y descent even though there is no prominent V wave. So here rapid Y descent in constrictive pericarditis is because of diastolic dysfunction of the ventricles. Okay, so that is what is your Frederick sign. So very simple. Even though there is no prominent V wave, but still there is rapid Y descent. That is called as Frederick sign, seen in patients with the constrictive pericarditis. So if you take the jugular venous pulsations, I mean the abnormalities in tricuspid stenosis, what is that you are having? You are having slow Y descent. Whereas in tricuspid regurgitation, what are all the abnormalities? The X wave, it is absent. Okay, that is one thing. V wave, it is prominent, right? Or V wave amplitude is elevated. And how is the Y wave? Even the Y wave is also prominent and as well as the rapid. So these are the waves in case of, and you have what is called the CV wave. Why? Because you don't have X wave. The C wave, it gets merged with the V wave. That is what you will see in case of tricuspid regurgitation. Then you take the specifics, like you take in case of the atrial septal defect. In atrial septal defect, like what are all the abnormal JVP waves? Number one, you will have a prominent A wave. So why is that you have the prominent A wave? Because more and more blood is entering into the right atria. So right atrial pressure is grossly elevated and atria has to contract very strongly in order to push this entire blood which the right atria has received. Right atria is actually received the additional blood. Apart from SVC and IVC blood, it also has received the LA blood in case of ASD. So right atrial contraction will be more prominent. So that is the reason why you will have a prominent A wave. Okay. Then how will be your X wave? You will have deep X wave. Because in order to accommodate that additional blood which is coming from the left atria, right atria has to relax maximally, and thereby you get this deep X wave. And how will be your V wave? The V wave, it will be a large steep V wave, right? Again, the same concept, right? V wave is due to venous filling. It should be normally SVC and IVC, but here even the LA blade is also getting added, so thereby you will have a large steep V wave. And same way, even the Y descent also is deep Y descent, or prominent Y descent will be there, because more and more blood is entering back into the right ventricle from the right atria during atrial emptying. So these are the abnormal JVP waves in the atrial septal defect. Whereas you take in case of the cardiac tamponade, what did we discuss? You will have the deep X descent and there is absent Y wave. Okay. Why this Y wave is absent? Because there is diastolic collapse of the ventricles in cardiac tamponade. So because of diastolic collapse of the ventricles in cardiac tamponade, the diastolic pressure is grossly elevated. Thereby, the atria is not able to empty the blood. And in case of constrictive pericarditis, you will have both prominent. So there is prominent X and as well as Y descent. And what about in case of the constrictive pericarditis? So in case of constrictive pericarditis, you have a dominant or effusive constrictive pericarditis. Effusive constrictive pericarditis means there is pericardial effusion and constrictive pericarditis also. So here there is dominant X descent, right? There is dominant X along with equally Y descent. Okay, so that is what you will see in case of the pericardial diseases. Then, so this is about the individual specifics of like what will be the abnormal JVP changes. Now, let me just discuss one important sign called as the Mace sign. What is this Mace sign? Mace sign, it is engorged veins on the undersurface of the tongue that tells that there is an elevated venous pressure. That is what is called as the Mace sign. Now, one important clinical scenario I will just show and then we will wind up this session. So, a 67-year-old man presents to the accident and emergency with 3-day history of shortness of breath. On examination, you palpate the radial pulse and notice that the patient has irregular heartbeat with overall rate of 140 beats per minute. You request an ECG which reveals the patient is in atrial fibrillation. Which of the following would you expect to see when assessing the JVP? Raised JVP with normal variation, large V wave, Canon A wave, absent A wave, and large A wave. So ECG is very clearly suggestive of atrial fibrillation. So in atrial fibrillation, what is the abnormality we have discussed? That there is absent A wave. Right. So these are some of the important points about the jugular venous pulsations. So the basic introduction, what did we discuss? The JVP tells you about the volume status, right? The internal jugular vein, it is lateral to the sternocleidomastoid, right? Whereas medial to the sternocleidomastoid, like what you have is the carotid pulsations. And why is that we are taking the internal jugular vein? Because it is in straight connection with the right atrium. Why is it right specifically? Because even left has the angulations. So we don't take the left. And the interpretation, like we have the waveforms like ACXVY, and that represents the right atrial pressure changes. And you need to know the abnormalities of the various waveforms. With this, we'll wind up this particular session of the JVP. Thank you very much.